Good morning, everyone. Up until maybe 2 or 3 weeks ago, I was pretty excited about this topic, saying, I'll get to talk about a lot of new drugs. And then we heard some interesting news, starting from late February into early April. And I was like, okay, Joe maybe knew something about this ahead of me and gave this topic to me. So I am going to talk about the small molecules in multiple myeloma. These are my disclosures. I'm going to start off by making a couple of different statements to kind of set up the stage. And you're going to see this theme throughout the talks that you hear. The first and foremost important one is myeloma is not one disease. And we've started to recognize that the natural history of certain subsets of myeloma are different. And we've started to think about designing clinical trials based on that information. So this monoclonal gammopathy to active myeloma transition is dictated by the myeloma cell biology, the immune repertoire, as well as what's happening in the individual patient's bone marrow microenvironment. So all those three things kind of make an important impact on the natural history of disease in a given patient. That's why we need to target the cellular pathways based on normal and abnormal plasma cell biology. Think about how can we modulate the bone marrow microenvironment as well as the immune dysregulation in a given myeloma patient. And that's where you're going to be hearing about a lot of different strategies when it comes to small molecules and immunotherapy strategies. And why is that important? From a myeloma biology perspective, this is a very old slide, one of the most utilized figures that we use to explain myeloma cell biology, that even in a given patient, you have many different myeloma clones at the time of diagnosis. And if we are utilizing one mechanism of action to treat those patients, we may be able to control one clone, but at the time of relapse, another clone emerges. And there is this clonal evolution and tiding concept, which helps us think of this more conceptually. And so combination chemotherapy is extremely important if we are going to have long-term disease control for myeloma. So this particular talk will cover data on venetoclax, which is a BCL2 inhibitor, and selinexor, exportin-1 or XPO1 inhibitor. And I'll share some of the challenges we have with each of these molecules, as well as some of the other molecules I'm just going to enlist that we should be watching out for. So, BCL2 inhibition, BCL2 is an anti-apoptotic intermediary within the mitochondria, which influences a cell's ability to either undergo cell death under duress or survive. And venetoclax is a BCL2 inhibitor. The early data that we heard about venetoclax activity in myeloma specifically, you're probably already familiar with the CLL data and will probably hear more about it, was from Shaji Kumar when he presented the data with relapse refractory multiple myeloma, specifically in the translocation 11-14 patients. So when these investigators embarked on this clinical trial, they started to observe translocation 11-14 patients having a favorable response. This may feel like a busy slide, but if you look at the left panel looking at overall response rate, you'll recognize that in the 66 patients, the overall response rate was 21%, but specifically in translocation 11-14 patients, the single agent activity was about 40%. And the time to progression and duration of response was fairly superior for those patients. And this prompted the thought that maybe we might be able to develop a biomarker-driven therapy for myeloma that targets the translocation 11-14 patients. And then the investigators also looked at this from a gene expression perspective on the plasma cells as well as the peripheral blood mononuclear cells, and found out that patients who have a high BCL2 to BCL2 L1 ratio, so that's another intermediary molecule within the caspase death pathway, that patients who have the high ratio actually are the ones who have the best response within that subgroup. So I mean, the story was was coming together that, we actually not just have a molecular subgroup that identifies with a specific small molecule, but you actually have an assay that you can utilize to predict, okay, this patient is going to respond to this therapy versus this patient who will likely not respond. So based on that, there was another trial Philippe Moreau presented combining venetoclax with bortezomib and dexamethasone, again, going after that BCL2, MCL1 pathway. And they too found that patients who had venetoclax combined with bortezomib dexamethasone had a fairly high overall response rate, specifically in the 1 to 3 prior lines of treatment, and translocation 11-14 patients benefited pretty nicely. And there too, the BCL2-L1 ratio came into play. So the high BCL2 MCL1 ratio patients actually had the better responses. This is an example. This is a very important example. One of the things that I want to share with you guys, and this is just a story, is plasma cell leukemia has an enrichment of translocation 11-14, and you know that plasma cell leukemia is a very aggressive clinical phenotype of myeloma, and patients die within 6 months of diagnosis. But this is a really nice story where venetoclax was utilized on a plasma cell leukemia patient, and patient responded very well, becoming MRD negative. These kind of stories are kind of unheard of. So all of these things were getting us excited about venetoclax, looking forward to the phase 3 clinical trial data, but we actually had a downer last week, and we're still trying to, we're still struggling with how to reconcile the wonderful biologic story, the clinical response, and the depth of response we're seeing with venetoclax combinations, but there's a higher incidence of death. So this is the Bellini trial, which was comparing venetoclax VD versus VD in early relapse myeloma patients, 1 to 3 prior lines of treatment. If you look on the left side, it's a very busy slide. You have this data in your packet. You'll see that the median PFS on the experimental arm is twice as high as the standard of care arm. The response rates are higher. There seemingly isn't a lot of difference in the specific SAEs, serious adverse events, grade 3 or 5, 3 to 4. But the number of patients who died on the study, that's the figure on the right, the Kaplan-Meier curve you're seeing. The red one is the placebo arm. The blue one is the venetoclax bortezomib dexamethasone arm. We're waiting for more data to try to understand why this happened, and whether there is still hope for this drug. My feeling is that the 737 MAX will fly again. We just need to figure out what really happened here. So is it active in myeloma? Yes. Which myeloma subset benefits? We just don't know. Is it just translocation 11-14? Is it the BCL2-L1 ratio high patients? No cardiac history. Is there a specific thing in the cardiac history that led to some of those cardiac deaths, role of prophylactic antibiotics or IVIG, if infections are an issue? So, we'll get to learn more about that over the coming months. The next pathway is the exportin-1 pathway. Exportin-1 is a protein on the nuclear surface. It's a nuclear export pore complex protein, and it helps facilitate the movement of different proteins, such as the tumor suppressor protein P53 and others in and out of the nucleus. So the hypothesis here was, if you block exportin-1, you're essentially trying to reverse or enrich those tumor suppressor genes inside the nucleus, and thus killing the cancer cell. So selinexor is the first-in-class drug. The initial phase 1 data that we saw was in a combined study looking at multiple myeloma as well as Waldenstrom's, where there was certainly clinical activity of selinexor, with or without dexamethasone. This eventually led to a larger phase 2 trial in patients who had proteasome inhibitor, immunomodulatory drug, resistant myeloma. And these data were presented by our colleague Dan Vogel from UPenn and published last year. This is just a salient features of patients' clinical characteristics. I do want to highlight that they really wanted to focus on that quadruple refractory, so patients refractory to bortezomib, carfilzomib, lenalidomide, as well as pomalidomide. And then pentorefractory, that included a monoclonal antibody. And what they saw was the response rates were fairly similar across each of those subgroups, a little over 20%. One of the issues with this drug, however, was the side effect profile. So it was very difficult to give on its own because of the nausea, the vomiting, the fatigue. If it wasn't a cancer drug, it could be a really nice weight loss drug. So the way that they have very aggressive supportive care measures during the first cycle of treatment. So if patients are going to have symptoms, it's usually in the first cycle, and you kind of manage them appropriately and get them through, and there's a GI tolerance eventually to some of those side effects. Out of the cytopenias, thrombocytopenia is probably more pronounced side effect observed. So, you've probably heard the news from the FDA. There was an ODAC hearing late February on the phase 2 data that was going to lead to accelerated approval, followed by a readout of the early phase relapse study combined with bortezomib dexamethasone. And the ODAC hearing, unfortunately, I was there as well, came back negative. So we're still waiting to hear from the FDA whether it gets approved as a single agent for those pentorefractory patients or not. Around the same time, this study was being done combining selinexor with bortezomib dexamethasone. And this is just a snapshot of what was seen in the phase 1 study, an overall response rate of 84% in PI non-refractory myeloma patients with a median PFS of around 17.8 months. Safety profile, interestingly, now that investigators had figured out how to utilize selinexor and deal with some of those side effects. The safety profile was a little better when combined with bortezomib dexamethasone. So there's a learning curve piece of it. We've been lucky in myeloma that a lot of drugs outside of the old-fashioned cytotoxics, we haven't had to deal with the NCCN guidelines with nausea, vomiting, how to manage some of those side effects. So you can, utilize some of the solid onc management strategies into myeloma and make selinexor tolerable for patients. So, there are, so the pivotal phase 2 had a negative ODAC hearing on the 26th of February. I believe the company meets with Karyopharm, with the FDA again in a week or two, and there might be some positive news. It might get, maybe approval or in a small defined subset of patients, and we may have access to it. But if that does not happen, then we have to wait out for the phase 3 to read out, which will be in a very different patient population, 1 to 3 prior lines of treatment combined with Velcade and dexamethasone. So, my original plan on giving this talk was to talk about what's to come down the road, and there are a lot of small molecules. They're listed here. We've got the CELMoDs, MCL1 inhibitors, bromodomain inhibitors, or PROTACs. They have several different names, but essentially targeting proteolysis within the cell, MDM2 inhibitors, and then some of the next generation proteasome inhibitors like miruzumab and oprozumab. The story's in dead with them. So that's about it. I would end my talk here, just acknowledging my team and hand it over back to Joe. Thank you.